Hi, everyone. I am Mary Newman, and I'm the founder of the Sudden Cardiac Arrest Foundation, and I manage the Cardiac Arrest Survival Alliance. And we are very honored today to have Dr. Ankur Doshi speak to us about survivorship um, in the first year. So I know a lot of you have questions about this, so um, we will proceed shortly.
Barry, just tell me when you want me to get started.
Okay. Um, Do you have my PowerPoint now? Yeah. Okay.
Yep.
All right. So this topic is about survivorship in the first year post-hospital discharge. And Dr. Doshi will be facilitating this. A little bit about the Sudden Cardiac Arrest Foundation. Our vision is to eliminate, oops, somebody else joining. Our vision is to eliminate preventable death and disability from sudden cardiac arrest and support people affected by SCA. Our mission is to raise public awareness of sudden cardiac arrest and initiatives that save lives through education, research, and community. And we're actually celebrating our 20th anniversary right now. The Cardiac Arrest Survivor Alliance is a program of the Sudden Cardiac Arrest Foundation. CASA is a place for anyone touched by cardiac arrest. And we try to foster an online community for patients, families, friends, caregivers, lay responders, and advocates. We provide peer support, information, resources, and access to experts like Dr. Doshi to help community members recover, reengage, and thrive. Dr. Doshi is actually the clinical director of the cardiac arrest service at the University of Pittsburgh Medical Center, and he is a member of the Sudden Cardiac Arrest Foundation Board of Directors. Here is a little bit more about the foundation. Okay, so yeah, Ankur, please start sharing.
Awesome. Well, thanks everyone for joining. I think you need to stop sharing so I can share, Mary.
Okay.
Um, while we're doing that, I'll just introduce myself and one of my colleagues who's here. So again, my name is Ankur Doshi. I am an emergency physician by trade and work with cardiac arrest patients kind of particularly. I've done that for, I don't know, 15 or 20 or something like that years. I've lost count. I can't count that high. It's more than 10. Um, and we are lucky at the University of Pittsburgh to have a cardiac arrest service where we have a number of us who are interested in this, in folks who suffered a cardiac arrest and their families. Um, and I'd like to just introduce Cecilia Rattay, who on my screen is over on the left there, but who knows on your screen. Cecilia is a nurse practitioner who works with us, and she actually probably should be giving this talk, but Mary asked me because I forgot to tell her to just make Cecilia do it. Which because Cecilia directs our outpatient cardiac arrest clinic, which we started in January. But we've seen a number of folks, for the last number of years who've had a cardiac arrest and watched them. So as I start sharing, just before I do that, real quick, just a show of hands, you can just raise your hand or use the chat function. Who is a survivor?
Hmm.
Excellent. And then co-survivors? Okay. And then others, looks like a couple others maybe too. Okay, great. So I'm not going to tell you anything you probably don't know because you guys have actually lived this experience. Um, I have only lived this experience as someone who has worked with people, but not lived the experience myself. But I just thought maybe it's a useful thing to kind of see how we've compiled information here at Pitt and from some other places and kind of categorize things that people tell us about survivorship. This is super informal, just, talk up and, like scream if you need something or raise your hand or put something in the chat. I'll try to kind of monitor that while I talk. Or Mary, if you see something in the chat, just let me know. There's nothing here that's like we don't stand on any type of uh any type of formality here. We're at the University of Pittsburgh and we talk about survivorship, and you guys don't need to know that like recovery is one of the links in the chain of survival, and in many, many respects, the most important, or if nothing else, equally important to the rest of the links. And I think we forget that in those of us who work in the hospital or in the pre-hospital space because we don't always see patients after they leave the hospital. Um, we want to kind of really go back to this concept that patients are people and not patients, right? We want people to be back and living the life that they want to live, whatever that life looks like. It may be a new normal, it may be an old normal, it may be something in between, but I think that's what's important. So let's focus on that. And then I like this slide that just says that sequelae of post-cardiac arrest survivorship are four things, if nothing else. They are definable, so we can look at it and we can say these are expected sequelae. They're predictable. Okay, so not everyone has the same sequela, but we can lump sequela into buckets for folks. And most folks, when they see a framework like that, it helps them kind of understand where they fit into it. Interestingly, for doctors, it's kind of independent of etiology for the most part. Now, there can be some etiology specific things, a heart attack or SCAD or, a respiratory event or something related to substance use disorder. But that actually doesn't change a lot of the sequelae, which continue really independent of that. And then I think the last part is they're modifiable. And that's the part where a lot of people are doing work internationally on it. And, when I've given this talk in the past, I actually wrote questionably modifiable. But I think the data over the last number of years has shown that we can do certain strategies to modify the sequela. This is really great work from folks in the UK. And it's a couple years old now from Resuscitation Plus, but basically they just asked people after cardiac arrest, what difficulties did they find? And for those of you who are survivors or co-survivors in the room, I'm sure that you could look at this and tell me what you think if it rings true or not. But speaking to folks, I think we find that this rings true, that many people find issues with fatigue and memory and anxiety, but there's other things that people don't always kind of think of as healthcare providers: pain, long-term, job loss, reduced independence, all of which are real. And if we don't kind of address them as a healthcare field and as survivors and co-survivors helping others, we probably aren't addressing things well. And so what we did here at Pitt and is kind of come up with a conceptual framework on how we could take these type of things we're hearing from patients and put them into buckets, for lack of a better word. And they're all a little interdependent, but they all are equally important. And so there's five buckets I kind of talk to folks about and that we kind of talk to folks about. And you could use different terminology for them. So one is functional or physical, limitations based on physical changes that happen to people after a cardiac arrest. One is cognitive, and I think this one is the one that laypersons expect the most in many ways after cardiac arrest. Are there changes in cognition or mental or thinking? And then there's some that I think people are never addressed in cardiac arrest, and which is the mental health or psychiatric or emotional sequelae. I use the word emotional for most of our patients just because I think it's a little bit easier to kind of think about early after an event. But we know that those are real. We know that folks have spiritual sequelae and changes that, on how they view their life and what's important to their life. And then overarching, there's this social domain. Um, the world changes. People have to change and adapt, and people change and adapt to lots of things. But I think as healthcare providers, I'm always thinking with our team is how important is this, and realizing that people do have these changes. It's not something we actually hear about a lot in med school, by the way. Um, we've learned about this and have learned to address it. And then, we can map this to, the group in Essex who's done this. And we can see that like a lot of these things map to what people find previously. Just in case, like I put some slides in it I've used for kind of more lay people who aren't really living the world. So this may not be super important to this folks, but when I think of physical or musculoskeletal things, I think of pain, neuropathy, motor changes, fatigue, changes with sensorium. When we talk about cognition, we talk about memory, attention, executive functioning, which is staying on complex tasks. I use the example of using an ATM or driving a car or making a turkey sandwich. Language. Um, when we talk about emotional, we know that three major sequelae have been really well defined, which are anxiety, depression, and PTSD or other repetitive thought experiences. And that sometimes substance use disorder plays a role either in the cardiac arrest or as a sequela. Oh, sorry, I didn't mean to put this one in here, but well-defined depression, anxiety, PTSD, a real thing. Spiritual, we talk about like existential questions or spirituality, and I've always wrote that this is relatively unique to cardiac arrest because it's a very large life-changing event. But I just wonder now if we've just better studied it and thought about it. And that maybe every medical event gives you similar things to some degree. And, if you are a marathon runner and you break your ankle, do you have spiritual or existential questions about it? But, that's a little bit hard to study and maybe lower stakes or maybe higher stakes, depending on, if that's your livelihood. But I think it's a real thing that we think about, where we talk to our patients and say, what kind of thoughts do you have? And then finally, the social domain, which is really reintegration and participation. How do folks return to work? What about travel and recreation, association with their community, family, intimacy, other relationship issues? So we kind of think throughout this framework when we see our patients. Um, and, the 2020 AHA guidelines are really kind of similar, and they recommend a little bit less this type of a framework, but more how can we identify these things? Um, and, actually active work at the AHA right now that I'm and others are involved in is, are we actually doing this? And I think the answer is unfortunately no, for most patients. But the recommendations are for a structured affect assessment for affective or emotional symptoms and fatigue for caregivers and survivors. So survivors and co-survivors. Um, I would make the argument that most folks aren't doing that in most places, but it's actually fairly straightforward to do. Um, we use things like the PHQ-9, the GAD-7, or other assessments of true uh, uh, sequela of fatigue, as well as mental health sequela for all of our patients, although we don't do it as much probably for co-survivors as we should. Another level one recommendation from the AHA, although it says the level of evidence is really less good, is that every cardiac arrest survivor should have multimodal rehab and assessment for treatment for physical, cognitive, and other impairments before discharge. One of the things we do at our service is we engage our physical therapists and occupational therapists and our speech language pathologists on all of our patients. And folks who have found to have any needs, we engage our physiatry, our physical medicine and rehab colleagues for it to really come up with structured inpatient or outpatient rehab plans, knowing that that really changes, people's long-term sequela. And, one of the really interesting modifiable things, back to talk about modifiable, is that there's a couple papers now that cardiac rehab, which is something folks do after other cardiac events, such as a heart attack or an arrhythmia, where you can go up with a structured, monitored rehab, physical rehab program, changes cognitive sequela after cardiac arrest. So folks who are more likely to who participate in cardiac rehab tend to have less uh, cognitive long-term sequela, which is like a fascinating thing and makes sense. But if we don't assess people and we don't refer people, it's hard. Um, One of the things we can talk about, but cardiac arrest is not a diagnosis that fits with cardiac rehab. So a patient who had a cardiac arrest, their insurance, if you use cardiac arrest as their discharge diagnosis, we tell this to clinicians all the time. If that's their only discharge diagnosis, their insurance won't pay for cardiac rehab. So we have to come up with a diagnosis that fits with something to get someone into cardiac rehab, which there are lots of, and we have to know about it. And we had to meet with our cardiac rehab folks to figure that out. We know that, and the AHA recommends that survivors and caregivers get comprehensive multidisciplinary discharge planning. So when can they return to work? How can they do that in some kind of expectation? I'll show at the end of the presentation, we actually have a 16-page discharge packet we give to all of our cardiac arrest patients that I know Mary has seen. I'm happy to give it to anybody on this call. It's not something proprietary, although we say if you use it, please reference us because we put the work in. But we do that, and it gives a lot of anticipatory planning. Because I think a lot of what we hear from survivors is I was basically told I was lucky to survive my cardiac arrest. I walked out of the hospital, I had no idea what to expect. Um, and I went out, as I say, to the ether and had to figure it out on myself. Well, that's probably not something. The great thing about cardiac arrest, that's not great, but it's great, is that these sequelae are predictable. So we know that folks are going to have sequelae within these categories. So we discuss it with our patients and we give them a discharge packet that's very comprehensive. It gives lots of different choices on things that could happen. Not that everyone's going to have everything, but at least if a survivor or co-survivor is feeling something, can they see, is this within the realm of normal or not? And Steve, I'm happy to send it to you if you pop your email address in the chat. Um, and then there's a to be recommendation for referrals for emotional support for laypersons. And that's something else we are working on here, but maybe not really directly related to the cardiac arrest survivors and co-survivors themselves, unless the co-survivor was the rescuer. um, which happens the majority of the time. The majority of cardiac arrest in the United States occurs at home, about 2/3, and the most likely person is to be there is a loved one, and that loved one often is the rescuer. Um, so. We know that debriefing that and discussing that and what that felt like and how that was like and what's it like to go back to that apartment where either you suffered your cardiac arrest or you did CPR on your loved one? What does that mean? And how do you move forward with that? So just some basic data that if you're interested, we surveyed our cardiac arrest survivors and found that more than half needed physical therapy. About 40% went to cardiac rehab. Another 40% needed occupational therapy and about a quarter needed speech therapy. Now, one of the really interesting things is when you survey cardiac arrest survivors, we tend to end up surveying people who survive, quote unquote, well, people who are good enough to be able to go home and respond to surveys. So we underrepresent sometimes what other folks need who have more deficits or more needs. So I think this is like a really interesting number because it's so high, even though, again, I think we're missing some of the patients who maybe need this the most. And in terms of the care coordination, we also surveyed folks, and of course this is system related, but almost 25% when the time we surveyed them needed some type of psychological support, and um, and about 20% needed a home nurse aide, and other people needed case management and social work, which we think is actually probably underrepresented, again, because and Cecilia can talk a lot about this, but one of the things we find in our early cardiac arrest visits, a lot of it is just helping people with simple things like refilling medicines or how many appointments do I have to make? And do I really need to see these 10 people that they sent me to? And how do we do that? And one of our strategies is we actually just hired a social worker who will embed within our clinic to really help survivors and co-survivors through their needs. Another strategy I wanted to just document for you guys, for folks who haven't seen this type of data, and this is done by Alex Prosciutis at Harvard, uh, who has worked with our group and other group, is that mindfulness or, thinking about and metacognition about the event actually changes patients and 1 year psychiatric symptoms or psychologic symptoms. So it kind of can decrease things like post-traumatic stress disorder, or decrease depression and anxiety. So patients who are more mindful can do this. And as a healthcare provider, I take this data thinking that I can't make people mindful and be interested in metacognition, but what I can do is tell them about the sequela so they can already start thinking about how it's going to look. And they can be thoughtful about what this is going to look within their own life and what it's going to take to get back to what they love to do and how they want to be. And I think starting that can be very, very helpful. Another thing we found is that sending patients home with a CPR kit can actually change their affective symptoms of depression. So folks who use their CPR kit that we send them home with have lower rates of depression and anxiety at 6 months. Now, unfortunately, that tends to be better for the people who are comfortable with CPR, but really, really hardy in the people who are not comfortable with CPR initially. Their rates of depression and anxiety went down if we sent them home with the CPR kit to send them home with for them and their family members to learn. And these are commercially available kits. They cost us about $50 uh, per kit. And there's a little blow up mannequin in it and some CPR instructions that you can get from the AHA. And let's just not forget that caregivers, friends, and family have similar events to their survivors. But what's interesting is while they have those, they don't necessarily map the same way in the same dyad. So Alex Prosciutti, again, who is a CASA member and SCAF researcher, is actually doing a research study now on dyad. So he's looking at survivors and their co-survivors together to see if how that maps. But anecdotally, it doesn't really map that the survivor and the co-survivor have the same experience, right? They have a very different experience. For patients who are unconscious in the ICU, their co-survivor has a large portion of time where their survivor didn't. The co-survivor, again, especially if they were a rescuer, have that entire event, while the survivor has a lot more of the physical limitations and other kind of things that come from there. So just worth thinking that it's that. So how do you move forward with that? Is the CPR research on survivors or caregivers learning after the event? It's so for Rachel's question, it was we sent them home with the kit and we just said, did you use it? And did people learn? And the answer was yes or no. And if people learned, then it helped the survivors' anxiety. And we did not research the co-survivors' anxiety or depression. We were really focusing on the survivor in that one. Um, Thinking that maybe it helps both, right? But it's a little bit difficult to know if this co-survivor was the rescuer or not, and if they already had CPR training or not, and if that learning CPR would make them feel better or worse. We hear anecdotally a lot of survivors who didn't feel up to their CPR are so worried that they did something wrong that we didn't always want to give them new CPR training and bring up that event. So for those on the call who kind of haven't seen this, this is Kelly Sawyer's AHA Survivor Statement, and I highly recommend you read about it. You can literally Google Kelly Sawyer Circulation 2020 and you can see it. And Kelly wrote the AHA Survivor Statement. She happens to be one of our partners and kind of independently came up with a very similar kind of pathway and a similar set of information. And it's kind of a really nice way of seeing it in an academic journal on the things that we should be doing, but also things that can maybe help survivors and co-survivors. Yeah, so the question about the psych services, this was just we asked people if they used it or not, and they said that. Uh, and Cecilia can talk a little bit more, but we refer a large number of our patients to therapy, to the point where my scripting is that almost everyone needs like a therapist after an event like this as a survivor or co-survivor, and it's better to refer you, and you choose not to need it than not to be referred. And I suspect that many people who could have benefited either didn't use it or didn't respond to the survey because maybe they needed it. So I think that data is biased. This is our discharge packet. It's kind of what it looks like. I will send it to Mary, or it looks like there's a bunch of people in the chat. I can figure it out. We'll figure it out and get it to everybody so you guys can see it. And that's actually all I wanted to speak about because I really wanted to, answer questions and hear from folks. And when I'm presenting, I can't see any of these people and makes me very sad. Cecilia, what big topics did I miss?
I don't think anything. I have everybody's email that they put in the chat with um our discharge packet attached, ready to go, and then Encore, if you just want to add the slides, I can send it to everybody.
Sure, you're fantastic. Holy cow.
Yeah.
This is why
Uh,
you should never have a doctor do stuff a nurse practitioner can do.
yeah, if anybody has any questions, let us know. Thanks for attending and being so willing to engage about something really hard that happened to so many people on here.
Yeah, and I know Mary, like when Mary and I talked about this, we really wanted to do a little bit of level setting with some slides, but really mostly to hear from folks and to,
Right.
hear about your questions and what we can help with. So
What do you
EMDR therapy a week, and it helps stave off PTSD care. And I think that's a really great statement. There is no doubt that I think early intervention from a therapy standpoint is really important, and it's probably something we don't do. Sorry, my phone is buzzing.
And we will send you the slides and transcript, etc., everything you need after this. So,
Good. There was a question. I think someone was speaking and I spoke over.
Emily, I think. Emily?
Hey there, can you hear me? Sorry. No, it's fine.
Yeah, we can hear you, Emily.
We can hear. I missed most of this, I think, but the CPR training idea, I think that's a good idea, but I also say, like, for myself, I did it about a year, maybe about a year after my rescue. I went to American Red Cross and I spent like a whole day there. And it was actually quite traumatic to do that. Like, I think it was a good release, but it was really, really, really intense. And then maybe like a year or two after that, I went to, or maybe 3 years after that, I went to one of the summit or one of the events in DC. And I was with actually Joe Farrell and Edie, I think, or Edie Farrell, and myself and my rescuer. We did CPR on a mannequin together, and it was like unbelievable how much of a emotional release that was. I would say it's good, but it's not easy to do that. That's all. That's my comment on that.
Yeah, Emily, great to speak to you again.
Yeah.
I completely agree. So when I first started this, gosh, again, 15 years ago, I made what I think is a mistake. And what we did is we got our survivors and co-survivors in standard CPR classes, and many of them told us they couldn't do that. Um, it could be triggering. Sometimes the other people in the class didn't take it as seriously as they did. So what we do is we send folks with just a home kit that they can use at their leisure, and they can do that in whatever space they want for safety. Um, some of our survivors say, like, I only want my loved ones to know, and I can't do this. Some of the co-survivors say, I'm not ready to do this. So we kind of give it to them as an option. Say, take this at home, you decide what to do with it. And we actually stopped helping people enroll in kind of traditional go to someplace classes because it just seemed to be less effective and really, really triggering for a lot of people. I think Mark has his hand up before you, Joe, and then you can go second.
Yeah, I was just curious if you could speak more about, I've had my own experience with fatigue, and I was interested sort of if, is it cycles of fatigue that folks experience, or what's the typical, or is there a typical experience of fatigue?
It's a great question. And, we don't have great data on this, right? Because fatigue is one of those symptoms that comes from many parts of the body. And what I mean is, like, some people who have fatigue have it's from their mental health, right? It could be depression or anxiety. For some people, it could be, an organ problem. Some people, it could be related to what caused their cardiac arrest. Um, I think we see things like this that are non-linear, which is, I think, a little bit what you're asking, where folks can have fatigue of something, be better, and it can come back, right? Whether that comes back because there's a new medical problem or it has to do with somebody's emotional state, or it has to do with, something else going on. But we do see it, and we know it's dynamic. And someone who doesn't have it right away could have it later very commonly. Because, it's not that hard. It's physically moderately demanding to be in the hospital, right? Like, the physical therapist will make you walk down the hallway. And I always say that it's actually cognitively very little demanding in the hospital. The hardest thing we tend to ask patients is to order from the menu, right? Like, we don't ask people to do complex tasks. And then you go home and you have to, like, do complex tasks in order to just get out of bed, right? Getting out of bed and making your bed is a complex physical cognitive task, which is probably why I don't make my bed. But I mean, these are everything that you do at home is um, orders of magnitude more difficult than we see in the hospital. And so we see people go home and they feel worse, probably because we never identified the fact that they weren't maybe ready to go home or needed a better rehab plan. And then we find it later as well. Cecilia, do you want to add anything to that?
I think people tend to, at least in my anecdotal experience, tend to report it as almost cyclic. And a lot of times, I'm sure as you all realize and that Encore just brought up, is that when you go home is when a lot of stuff gets unveiled. So usually I recommend to people that, if they're doing well enough that they can return to work, to do it in a really stepwise fashion. I don't know if anybody else here tried that, where you work, a morning and then you take the afternoon off, or you do like 2-hour blocks. Obviously, everybody has different occupations, everybody has different, job flexibility type of environment. So, and it seems like, at least what patients have told me, it's been more cyclic than anything else.
And then we'll get to Joe, then Kathy, and then move down the line. But one more thing worth saying is I think it's important for, those of us who are clinicians on this space and co-survivors, and I think the survivors already know this, but maybe for them as well, is that uh, compared to other diseases of this magnitude, there's fewer external sequelae. And what I mean is that most people who've had a cardiac arrest go home and they go back to work, and people go, "Oh, you're here. You look like and like, let's get back to, 8 hours a day of whatever that is, right?" And I think everyone wants to get back to 8 hours a day for the most part of what that is. But, it's not obvious, not like someone who's can't move the left side of their body from a major stroke or something like that. And so I think it's important for us to remember that, and important for advocacy in this space to say it's important to go back slowly. It's important just because someone, quote unquote, looks okay, doesn't mean they haven't had a life-changing event. I think, Joe, you were next, even though you don't know how to put your hand up in Zoom, so I'll make fun of
Yeah, and I couldn't find it on here, Anchor. Excuse me. I apologize. No, I just have a couple comments, and I appreciate Emily's comments about CPR. And I'd like to reiterate, I think he said it was 3 years post-arrest that he redid CPR with Edie and I and Ed Cossack and others at the rally in Washington, D.C. And I think it's part of the journey that as the more experience you have as a survivor, the more your life will change. And fortunately, for me and my wife, Edie, as a co-survivor, the more involved we got with teaching CPR, the more therapeutic it was for us. We're going to be speaking about this at the CAS conference, so a little plug for our presentation, and Mary's going to be talking there, and Gina. But the other thing about back to work, I think it's interesting. Again, we're all individuals. I'm a retired physical therapist, and so my work's was physical. And 1 month post-op, of course, I knew a lot about rehab, right? So I pushed myself and got in pretty good shape fast. And I wanted to go back to work in a month. Both my cardiologists said, no, cool it, will you? What you don't realize is part of the reason we think you went into cardiac arrest is you had a very stressful job. You had big demands upon you. You're not going back for another month. And I really took off another 5 weeks. And I'm really glad I did, because not only does your body have to heal, but I think we've talked, Ankur, Dr. Doshi is talking about, is our minds. And it takes time. And those are my comments. Thank you.
Yeah, and then we'll get to Kathy, but Steve, I like your comment in there too, right? For some people, it's actually okay to go back, right? If you're ready, you're ready.
Yeah,
But you're the only one who knows it. But the most important thing I saw in your comment there is that there was no help from the hospital on any occasion, which is 100% true. And I sit on the AHA Systems of Care Subcommittee Survivorship Working Group with a number of other folks with CASA. So, we are interested in this and interested in kind of promulgating information for folks as much as we can. So it's active work we're doing. If you're very interested, let us know. We're happy to kind of help and find you folks. And Julia, 18 months to go back to work, it's a long time, right? And like that, hearing that something is sometimes really, really long is sometimes really hard on your mental health as well, right? Because you want to get back to normal as soon as you can. Perfect. I love it. Lynn, you have a best doctor ever. Most people don't get that lucky. Kathy, you had your hand up. Go ahead.
Okay, so Dr. Doshi, you were actually my doctor at Presby when I was there, and I got a lot of the things that you sent home and everything in the CPR kit, and I do remember one thing is like that was triggering just seeing that. Thinking about it right now, it's triggering. I remember the first time because I worked at Children's Hospital and I had to go and retake my CPR class. And it was so difficult going in there. And I knew the instructor and she knew I had the cardiac arrest. And I said, but one of the other instructors didn't. And I was, doing the CPR on the mannequin and she's like, oh, you have to push harder. And I'm like, I can't do this, and it and she's like, oh no, you just have to push harder. And I was like, no, I can't do this mentally, and I had to I've done it since then, but it was very difficult doing that. And
Yeah.
through, some of the other things you said, like easing back into work. When I was off for 2.5 months. Then when I went back to work, I went into the office 2 days a week, but I worked from home 3 days a week, which gave me that chance that if I wasn't feeling good or if I was tired, I could go and lay down on the couch for half an hour or something while I was at home. So it really mentally, it also helped because I didn't feel like I had to be on, 8 hours a day, 5 days a week at work. I could take that break from everything, and my load was less of a load. So it definitely helped. Um, but I know one of the big things is you had connected me with somebody, who also had cardiac arrest, and talking to those other people and then joining this was such a help to me. And then I did seek out a counselor to talk to, and I recommend that to everybody and any patients you have. If you're not a survivor or you're a co-survivor or you're a physician, recommend that highly to anybody because I never had anxiety until after my cardiac arrest.
Thanks for sharing your story, Kathy. Not to out you too much, but I remember when you called me the day you went back to work. I remember exactly where I was in the car when you called. I'll
Yeah.
never forget it. I remember the street, the street that I was on, and how hard it was for you. And sorry, we triggered you by sending the CPR kit home. Bad about
No, but I shared that with my nephews who,
it. Yeah, I feel
used
bad,
it.
but one of the things you brought up is, and I don't want to tell your story for you, but
That's okay.
we know that folks like where and how things happen and things that bring it up are really triggering, right? And
Yes.
knowing that's going to happen is going to be really, really important, not just blindly walking into that
Hmm.
space, which I think can sometimes happen. And that's, then how do you get yourself out of that space like that?
Right. Right.
So. Yeah, absolutely. And so what Kathy was talking about, we have a program, like an informal program where we try to match survivors with near peer support. So other folks who've had a similar event. Obviously, it's impossible to match completely. And we offer it to pretty much everybody. Lots of folks turn us down, I would say, still Cecilia, during the hospitalization, and many more say yes later. Because they're like, oh, wow, this was really, really useful. Um, and so that's something we do a lot. And before I get to Anne's question, since I think she had to run away, is it Sando? Is that whose question is up? Is that...
Oh, Otto, me?
Yeah, oh, Otto, sorry. I
Oh,
couldn't tell which was the front and which was the first and the last name.
Oh, yeah. No, thank you. This is my first time doing anything like this. I am about a little over a year after my incident, and it was on the street. I got saved by a passing nurse. It's a crazy story. And waking up in the ICU to my loved ones who were staring down at me and having no memory, no idea of what I went through, and being told was like waking up in a dream. I then went back to work, maybe, I got the ICD and all that stuff. I went back to work maybe a couple months afterwards, and there was a lot of moving and shaking to get around me because, I was a principal piece of the architecture of the work. And so when I finally sort of woke up from the honeymoon of like feeling better, getting into the gym and all that stuff, what really was the thing that is my downfall was the psychological bit. And I've just started to go into therapy. And I guess my question is, or my experience is, it all feels okay when you sort of dissociatively going through the motions, going to work, going to your doctor's appointments, moving step by step. And then when I came to a point where I could take a hiatus, I knew I needed it. And once I had nothing on my schedule, everything started to come back to get to really, really dark places where I knew instantly that I would need to get into therapy. And I guess part of what I'm sharing this experience is this something that you've seen that, like, let's say a year out, you know what I mean, almost on the anniversary, people start to really experience, what they kind of missed because it's all something that you experienced, but you weren't, I was in a coma. You know what I mean? I have no memory of it. So I guess that's my roundabout way of asking about other people's experiences with this and your sort of understanding of that.
Um, I think you're getting a lot of great comments in the chat about it, but and not being a survivor myself, of course, I could tell you like what we hear from folks. I think it's really common that emotional or psychiatric or mental health sequelae are delayed.
Mhm.
I think it has to do with a lot of things. One, you may not have any memory of it. Two, um, it's like having a baby, right? Like, I don't want to make it that simple, but like the first couple of months is just you're just getting through the day, right? Like you don't have time to process about this massive thing that happened. I think the third one I hear for some folks, and may or may not resonate with you, is that at some point we all expect a major life change to happen, but then we expect to get back exactly to where we were. And then at some point it comes and says, why is this different? And trying to understand that too. And so I think for some folks, it kind of hits them at different times. I've, and I think Cecilia can talk a little bit about it too, but I kind of really think of this between 3 and 6 months later is the first time it really, really hits people sometimes. Some people really get it right away. For some people, it's later. It depends on how much you remember the event. Um, and what's interesting is for the co-survivors, it may be earlier, I think, a little bit, right? Because especially a co-survivor who's a rescuer is now living the experience of watching the cardiac arrest and reliving that. And they have it so early. The survivor sometimes gets it later, and there's this big dissociation that's actually really challenging in terms of relationships. And so I think what we do in terms of just telling folks is tell folks that this can happen and it can happen later. It may be 6 months, it may be a year, it may be on an anniversary, maybe it's if it was at a baseball game, the first time you go to a baseball game, or maybe it's the first time you play pickleball, or pick there. It's almost impossible to know what it's going to be, but things will bring it up. You know, maybe having a webinar like this brings it up for somebody, right? And then they have to deal with that. So I don't think you're unusual for that.
Mhm.
Um, I think everyone has it a little different, and you kind of have to have some anticipation that it could happen.
Mhm.
And that I think helps a little bit, but that's why we tell folks therapy, really early that this is going to be an important thing. I don't know when it's going to be important, but it's way easier if you already had a therapist you saw who said, I don't need you anymore. And then you call them up and say, I need you now. How do I get back in? I find that's easier for patients than having to then find somebody, which takes some time.
And also having the experience of other people talking, I've had other people reach out to me and say, this happened to me too, and like really feeling seen. So thank you for that commentary. Thank you so much.
Yeah, I mean, I think that was Mary's whole vision on CASA is that we
Mhm.
know that This is a rare event, right? And it's I'm sure all of you know, you guys have all been survivors, that it's a rare event that people survive. And that brings things up, and having a shared community space is important. I use the example in the hospital a lot that if I tell a patient in the emergency department they have cancer, which is awful, they have a friend, neighbor, or loved one who has cancer. Everybody knows somebody. They at least can have some place to start, right? That person may not be right for them, but they at least have someone to reach out to and say, oh my gosh, what does this mean? Cardiac arrest is not the same way. So you have to seek out somebody, or someone has to seek you out, right, to figure that out. So, I personally think that these kind of things are really important. Cecilia, what else would you like to add?
I mean, it's been my experience that the people have the same thing where sort of like almost like the adrenaline rush of everything sort of washes out and then it hits you like a ton of bricks. Um, and especially when people are approaching anniversaries, like I didn't have a cardiac arrest, but I did have a um traumatic brain injury. I was hit by a car on my way to work 12 years ago when I was crossing the street. And if I see January 28th anywhere, like I was holding my car insurance card once, I just like threw it all of a sudden. So, I mean, like it's something, sometimes dates, sometimes numbers really sink in. And I'm sure there's a lot written about it that I haven't delved into, but that's a very common shared experience, I think, also across other traumatic events.
Yeah, interestingly, I think cardiac arrest were actually a little bit more on the forefront of this, which is why I said like the spiritual or this kind of cognizant stuff is something I think we have thought about more in cardiac arrest. Again, I don't know why, but it's not kind of in the medical literature as much. Anne was asking about AICDs and some PTSD and triggering and all the stuff that Atoe, is that how you pronounce it? Okay, perfect. I just mentioned, and then you had walked away, so I didn't want to address it. But again, anecdotally, we have patients whose AICD gives them lots of comfort. And then we have patients whose AICD gives them a lot of anxiety. And I never know which one it's going to be. And it tends to be fairly polarizing for folks one way or another. Your question about who gets an AICD, which I think was your question, really. Um, you know, this the cardiology answer is that if the person had a cardiology problem stopping their heart that has not gotten fixed, then off and they had an arrhythmia, then they are normally an indication for an AICD. But someone who has had a cardiology problem, say like a massive heart attack that was then fixed, isn't always a candidate for an AICD. And again, for some people, it's very, again, they feel it's very, I don't want to say, I don't know what the right word is, but therapeutic to have it, uh, you know, uh, and for some people, they really dislike it. I know a couple cardiac arrest survivors who petitioned with their cardiologist that, if they didn't have an arrhythmia for 10 years, could they get it out? Because they just didn't like it so much. So if you've had it, yeah. So Steve, it's really interesting, right? But it's the real event one. So I've had patients who have had it go off, but quote unquote didn't need it. And then it just hurts a lot. And then they really, really want it out. So
Well, I went both ways. I've had it go off early on when they were adjusting everything. I got shocked probably 15 times different, in the first year or two. Then once everything got adjusted, then I had a couple of events that they said would have been life-threatening had I not had it. And so
yeah.
then, like I said, that's when you change your opinion and you just go, okay, and you make the adjustments you have to make.
Yeah, and Lynn says it made my PTSD worse. Like we see this. Yeah, you're not unusual, Lynn. And you'll hear from and nothing. Sorry, not to put you on the spot or anything, Steve or Anne. You'll hear more from people who say how they like it and it feels better, and you won't hear from the people who don't like it. Like it just tends not to come up as much, and so you're not that unusual for not liking it.
Well, you
Uh,
also learn. I've learned sometimes when I start feeling a certain way, like in there, I know it's going to go, and I literally, I've been exercising sometimes, and it literally got off an exercise beat, hit the deck, and then it went off. I mean, within a couple
yeah,
seconds, because you just,
yeah.
I knew I could feel the tachycardia going, and I went, oops, got to get off this. And
Yeah, and there are people who the cardiologist will take them out, but I would ask your doctor to see. I mean, if you have a hard indication for it, though, I would recommend keeping it in because it is life saving. But everyone has to be a little bit on their own, right? You live this, you live this life, nobody else. And you had unmuted. I wasn't sure if you wanted to say something as a response to this.
Yeah, it's just my biggest problem is returning to work. And I just wondered how you help people navigate that in terms of um, understanding what is a realistic capability and expectation more from cognitive impairment than from physical. I'm a year out and I've tried to go back to work and failed. And just, I don't know how to navigate that. And what's realistic? How do you figure out realistic expectations?
Cecilia, you want to go first or me?
I can start if you want to add. So I think it's important to recognize, and I promise this isn't a cop-out, that everybody is on a different timeline and that our understanding of recovery after any type of brain injury, including cardiac arrest, is limited, despite the amount that we do know. So I think that each person is really the expert on what their limits are, and that I think I maybe touched on earlier that if it's possible that people only work like 2 or 4 hours at a time or 1 or 2 days a week, but I know that everybody's work environment is different. But go ahead, Doshi.
You hit the important things. I think the other thing that I guess I would say, Anne, to you and to everyone on the call is having routine structured assessments of cognition is important. And one of the things you won't see, just as you guys said, we've heard this from many survivors, like, they said, good luck, get out of here from the hospital, but no one really told you where you were. So we use the MoCA test, which is a test built for dementia, but we've modified it for cardiac arrest, and we follow people serially on that and say, what is your cognition? And if folks have continued issues with cognition, we really push for our physical medicine and rehab docs to work with them and work with a rehab plan. There is a well-worn path for other cognitive disorders and other neurologic disorders for rehab, right? Like everybody knows someone who had a stroke and they did rehab and then they got a little bit better or not better, right? But like there's a pathway to do that. That pathway should exist in cardiac arrest as well. And, if I was a patient who was, or, a survivor who was still not feeling there, I would ask my doctor, okay, what do my assessments look like? Where am I? Because if I was here and now I'm here and getting better, well, great. What does that look like for work? But if I was here and I'm still here, what does that look like for my work, right? And I think without that data, it's really challenging for folks because, well, if we don't do that, then we just say, go back to work. And you're like, well, how do I go back to work if I don't know where I am? And everybody's work is different, right? Your work's different if you're a nuclear scientist versus a doctor, right? They're probably different important things that you need in your brain. And so I think it is different for everybody, but I think we should keep assessing it. And I would recommend if someone hasn't gotten like an assessment, a neurocognitive assessment from one of their doctors, is to get that or be referred to someone who could do it. Our local system happens to be, we actually use our traumatic brain injury clinic for this. And so we refer people to the people who take care of people with traumatic brain injury.
So I was lucky enough, I'm in Atlanta to get in the Shepherd Center for non-traumatic brain injury, and did 3 months of speech, and my neuropsych eval's normal, and they say that's not uncommon. I have more fatigue and problems with executive functioning and overstimulation. But as a physician assistant, they ethically cannot clear me for work because of the importance of what some of the decision making and the endurance. And I just don't know how to navigate getting back in the medical field when that's not a space you can work in for a couple hours and go home or go lay down.
Yeah, I wonder, have you ever thought about doing something adjacent to clinical work?
I've Googled, non-clinical positions, and it's a little overwhelming for me. And I think that's part of my history is trying to navigate something brand new is additional stress. And
For sure.
And the problem is my positions were very like critical care, high surgery. So
Mhm.
People are like, oh, just go back and work at a pediatrician's office, but I've never done that. So learning
Yeah,
all brand new things is harder than trying to go back to what I know.
but you already know, yeah. I'm sorry, that's a really heavy load. Um, if I can offer you anything, it's hope that it will get better even if it takes longer. Um, I mean, we have some people that it's, with other types of brain injuries too, it's been 2 or 3 years, sometimes 5 years before they can really get back into the full swing of work. But that if anybody alludes that you should be better by now or that you should be on some timeline, that they just simply don't know what they're talking about.
So that's
Um,
something, it's only been a year. And if I look back in a period of even a couple months, I can still see improvement. So you're optimistic that with time, there's a chance things will continue to improve.
yeah.
Yeah,
Yeah.
we definitely see people who tell us things are different. It's been 28 months versus 30 months. I feel like a different person.
Interesting.
Um, so it is different for folks. I would love to actually hear the folks on this call who are other survivors, and your experiences. But I don't think it's unusual for people to feel that they continue to improve for a much longer period of time than you think. Um,
Because I was stressed the first 6 months is when the most healing comes, the next 6 months, and then with some of the hormones go down and there's not as much brain remodeling, but you can slowly improve, but it's just hard to know how much. I know that's very individualized.
Yeah, and there's an intersection between our, neurohormonal and brain remodeling and all the other sequelae that goes with cardiac arrest, right? Like it's not like you can map it to an MRI, right? If it was that easy, um, then everyone would be better, right away. So I think it takes time. I think I wouldn't be, I agree. The best thing to say is that there's continued hope that it's going to continue to improve.
How important is it to continue with therapies and stressing yourself versus more low stress? Because I tend to overdo it and go through these cycles versus just more of a steady state. And then I feel like I'm not stressing myself if I just don't push.
Unfortunately, not a lot of data to guide us, right? We don't just have a huge data set. I wish we could to tell you what the right way is. Um, I think of the brain and I think of the body as like, kind of you stress yourself a little, but not too much, and you kind of keep moving forward. Does that make sense? It's kind of how I think about it, but there's
Yeah.
not a lot of data behind what I'm saying. I think it's a little bit different for everybody. Um, I think having a team that can continue to help you do that, like a medical team, is what's really important, right? Like who can kind of guide you? What does it look like next month or the month after becomes really helpful. And that person could sometimes just be informal too, right? It could be a loved one or a friend who's in the medical field who can help. I don't think there's specific cardiac arrest data on this.
Hi, Ankur, Joe Farrell has a question.
Yeah, and just so you guys know, I unfortunately need to go pretty soon because I'm supposed to pick up a kid from practice, but she hasn't texted me yet, so that's good.
So, Anchor, I'd just like to make a quick comment about ICDs. I think one of the things that was really missing in my uh, discharge planning when I left the hospital 17 years ago is I didn't even know what warning signs this device would give me if something was wrong with it. And 10 years out, I had a buzz. I'm sitting there reading the newspaper on a Saturday morning, and briefly, what did I do? I luckily got a hold of my EP cardiologist. He called me right back and he told me, he goes, go to the ER, we'll check you out, blah, blah, blah. What it turned out was I had a fractured lead. And you talk about the trauma of that. I've had that happen to me 3 times now. And just something I just think the discharge really needs to be a bit more detailed with what to expect at the ICD. What does this mean? What does that mean? How often you know, do I come in to get an interrogation from, say, Abbott Labs that makes my ICD? Is it once a year? Is it twice a year? et cetera, et cetera. So I'm just hoping we can add a little bit to that to our discharge thing. And I know from some of the data that about 75% of people that have cardiac arrest end up with an ICD. So that's pretty high proportion. Thank you for your great presentation.
Yeah, thanks, Joe. I think you're bringing up that we are awful at communicating in healthcare to our patients overall, let alone in this most stressful thing where you get 55 pieces of paper at the end and expected to be like an expert on all of them. Paul, I love the low tech way of doing it. I won't make
Okay.
fun of you because I don't know you as well as Joe, so.
Okay. Well, I was just wondering, first of all, I think Pittsburgh is, I'm happy that you guys have the services you have available to patients, but I'm just curious, and maybe other people can answer this too, but when you guys have conferences for this, right? Every so often. Are other hospitals across the nation interested in what you guys are doing? Do they ask? I mean, I'm just curious, how many other hospitals around the nation are like yours?
Not too many, I think.
Yeah.
Okay, that's what I
I'm trying to
thought.
be politically correct. Um, this is a job that doesn't pay very much. Um, this is not cardiac arrest, and follow-up and discharge packets is not something the hospital has to report or get paid for.
Uh-huh.
And this is like a huge pet peeve of mine. This has been my career, and it's really hard to export what we do here to other places. Now, it doesn't mean that people aren't interested in it. And as I said, I'm on a working group at the American Heart Association, and we're really interested in this. Um, how do we get this information to people? And it's challenging. But healthcare in the United States is a lot about finance. I'm sure you all know this.
Hmm.
The hospitals are required to report discharge information to patients with a stroke. It's a national reporting requirement. They're required to report their data after a heart attack. They are not required to report most of the data after cardiac arrest. So, um, pie in the sky, if I could fix it, I would make the hospitals have to report it. Because if they had to report it, then they need to build a system to do that. We are working actually on a survey right now that we're going to try to send out through the American Heart Association for people who take care of patients after cardiac arrest and say, what are the needs that you guys have? What are you guys actually doing? What can you actually give? And then to build a toolkit for them. But that's, a lot of work. And then the hard part is not only once we do it, is how do we put it in the hands of the people who will actually use it. Uh, but I think these kind of events are really helpful. And finding this community. There a lot of this information, I think, Mary, you have on the CASA website, right? Um, so a lot of our stuff that we've kind of done and I've written with Mary and we've put on the CASA website. Happy to help.
Hmm.
I'm always happy to speak to people to see if I can help as well. But you're right, it's not a lot of it. It's just that this is a disease that has champions who are scattered about the country.
Yeah.
Mhm.
To say the one answer.
There are some more post-hospital discharge follow-up places sprouting up in the United States. One is at Yale. A lot of them, if you go to look them up, they're under the auspices of what's called a neuro recovery clinic. And that's going to be a lot of different types of brain injury. And then there's also under post ICU follow-up clinics too. So there might be some places close to where you all are that might fit that bill. And when you describe your pattern of symptoms as something that would fit in with either the post ICU
Right.
syndrome clinics or the neuro recovery or the catch-all brain injury clinics.
Hmm. Well, I'm at 10 months since cardiac arrest. So thank you, Anne, for kind of going over your case. But even though I feel like I have, really progressed pretty well, but anyway, I just have found that these type of groups have been the most helpful for me more than anything, because I can't even talk to my cardiologist, or I couldn't even talk to my cardiologist because I actually had my cardiac arrest at cardio rehab, which was wonderful because I couldn't have been in a better place. It was faster than even being in a hospital. But, I can probably talk to my primary a little bit about it, but it's frustrating that I can't talk to people in the heart field even about it or where I'm at with it.
Yeah, and what you're saying is actually a really interesting phenomenon. So my wife is an internist, and because of the demographics of cardiac arrest, right? Most out-of-hospital cardiac arrest patients unfortunately pass away, right? Most die. Most PCPs have very few patients within their cohort who have suffered and survived a cardiac arrest. So they may know
Yes.
one or two survivors at a
Yeah.
time, and in their career may know five. So what they don't see is this kind of predictable, defined sequela and can giving people guidance, anticipatory guidance. So that's kind of why we built the service partly, right? Partly to take care of the patients, but partly to help do this. And one of the reasons we very politely asked Cecilia to please do a post-cardiac arrest clinic out of her extra free time was that like there aren't other places to refer people to. There's a couple in the country, and people are trying to do that, but they're hard. They're scattered. Groups like this, though, are helpful because we can, you can find people who can do that, and we can help find those resources for you more closer to you.
Okay. Thank you.
Yeah, I always say that, like, I don't think I know very much. Like, I don't think I know like any more science than any other doctor about this. I've just talked to more people who've had a cardiac arrest than most doctors. And so when you do that, you find these patterns, right? And so I think that's what we found as a group. We said we talk to people, we hear the same things over and over and over and over again. The themes are all the same, the variations are there, right? Not I can't say that everyone has the same experience. That's not fair. Everyone has their own unique experience, but the themes are pretty similar. So using colleagues you meet in places like this, I think can be really helpful for most folks. My daughter is texting me and saying practice is done.
Well, thank you so much, Dr. Doshi. This has been amazing. Thank you so much for your insights and guidance. We really appreciate it. And thank you to everybody who joined today. We hope this was helpful to you.
Yeah, I think it's mostly Cecilia, so let's give her a round of applause to
Yay.
start.
All right.
I dropped my email address in the chat. I am happy to, speak to anyone if you need something. I may refer you mostly back here because I think this group is great. But definitely anything we can help with, we will, and anything we can do. We haven't yet opened our clinic to non-Pennsylvanians, Anne. We hope one day. We actually do. That would be like my dream. Cecilia is giving me a look because she takes zero salary to run clinic half day a week. But I think the dream would be at some point to be able to help anyone. But that's a little bit of a lift right now.
Hey, I'm a Penn State grad, used to work at Heinz. Does that work?
You got to be in this. You got to be in Pennsylvania for us to see you by tele. That's the law.
ID, Steve.
But please let us know
Can
if
I
we can
use
help at all.
VPN? What if I use VPN? Can I put it there or something?
All right. Thank you,
Hi,
everyone.
everyone.
Thank you so much for
Thank you, Anchor.
joining us today.
Anytime. See ya.